This meeting is now being recorded.
The lived experience of nurse health policy advocates. Committee Chair Dr. Tona Leiker, Committee members Dr. Vi Wilkes and Dr. Dawn Adams. Nurses who practice at the intersection of public policy and personal lives are therefore ideally situated and morally obligated to include political advocacy and efforts to influence health policy in their practice. Problem statement. There is a deficit of nurses engaged in the role of health policy advocate. Exploration of my nursing practice presented a need for study on a nagging and seemingly recalcitrant issue of the lack of nursing engagement in health policy advocacy. I have had the pleasure of working and networking with nursing leaders who are firebrands, making a difference in advancing the nursing profession and the health of their communities. These nurses have been leaders in health policy for decades, repeatedly taking on positions of leadership and stepping out onto the public stage to respond to perceived needs. But nurses advancing to take up the role of health policy advocacy was not growing and remained stagnant. My goal for this study was to unearth study findings that could give insight into the reason for the deficit of nurses engaged in the health policy advocacy role. Purpose. This is a phenomenological study on nurses who are in leadership positions in health policy advocacy in the United States and looks into the experiences that form their decisions to become involved. I saw the persistent engagement and effectiveness of nursing leaders as a shared singular phenomenon that must be bound by universal characteristics. Those universalities or essences of the phenomenon that these nursing leaders presented were key to tapping into powerful knowledge that could explain their engagement and effectiveness and could be used to grow the body of nurse health policy advocates. Research question. Van Mann in 1990 holds up the lived experience as the singular vehicle through which a phenomenon can be successfully studied. It is where the phenomenology begins and ends. To this effect, my research question was, what are the lived experiences of nurses who engage in effective health policy advocacy roles? Methodology. I knew of several leaders in health policy through networking within nursing associations and nurse health policy educational conferences. I recruited from this pool. Cavell in 1996 cited interview studies as quantifying the number of interviews to be around 15 plus or minus 10 to reach saturation, so I settled on 12. Many of my participants were out of state. To ensure equity of access, the IRB required that all participants be interviewed by telephone, even those who lived close by. I conducted guided interviews that began with an opening grand tour question, followed by 5 to 6 supportive questions designed to ascertain what was important to the participant while maintaining the dialogue within the boundaries of the research question. My intent was not to ask leading questions that may in any way damper original thought. Interviews were recorded via digital recorder. The audio file was downloaded into Navivo 10 software, and transcriptions were ordered from within the software. I, as researcher, was the instrument in this hermeneutic phenomenological study. I collected data without intermediary, and my analysis was the solitary analysis of the interview text. Specific to the phenomenological method of analysis and framing the study within Pars's nursing theory of human becoming will be described. Scope and limitations. The act of being engaged in health policy advocacy was exampled in such efforts as educating public officials, other nurses, providers of health care, or the public on health policy, building grassroots support for health policies, holding positions in elected office, holding leadership positions in nursing associations or other associations whose purpose in whole or in part is to shape health policy, or an appointment to the state or national position of leadership in government whose purpose in whole or in part is to improve health outcomes. Ethical considerations. Participants were identified as Nurse 1, Nurse 2, all the way up to Nurse 12. Audio files and transcripts are password protected. Transcription service confidentiality agreement was received. Identifiers were not used in presentation of results, and transcript files will be kept for 5 years, password protected. Data analysis. This is a word cloud of all 12 interviews. Nurse is at the center, surrounded by health policy. The lived experiences were very much action-oriented, as you can see in the amount of verbs used: going, think, work, involved, know. Demographics. Minimal demographic data was elicited from participants. All participants were female. Age was assessed using a 10-year increment range. 7 participants are between the ages of 65 and 75, 3 between the ages of 55 and 65, and 2 are between the ages of 45 and 55. Basic nursing education consisted of 4 diploma degrees, 1 ADN degree, and 6 BSN degrees. All participants except 1 had graduate degrees, consisting of 6 terminal degrees, PhD, DNP, or EDD, and 4 with master's degrees. 3 participants were nurse practitioners. Some of the participants held additional nursing certifications not included in these demographics. Most study participants fall within or just outside of the baby boomer generations, defined as persons born between 1946 and 1964. The dominance of this age grouping among study participants was not purposeful. The homogenic age of the participants speaks to my experience and practice and review of the literature studying the recalcitrant problem of growing the body of nurse health policy advocates. This is illustrated in the lack of engagement of diverse generations of nurses in health policy advocacy. Data collection and analysis. All 12 participants were interviewed by phone to ensure equitable access. Audio recordings were uploaded into Navivo 10 qualitative software. Transcripts were ordered from within the software. The text of the interview was then hermeneutically analyzed using a modified Stevick-Kolasky-Keen method and a modified Creswell analysis for phenomenology. Analysis began by minimizing any bias I may have. This was done by positioning myself in the study as one who is familiar with health policy, has networked with participants, and has personal affiliations consistent with a more liberal ideology. These experiences and patterns of thinking were set aside, as much as possible, creating an epoch as free as possible from prejudice and presupposition. The text of the interviews were read and reread to become familiar with it, while jotting down memos in the margins as possible emerging codes, themes, patterns, and significant statements. Statements that are significant to the description of the experience were identified and transcribed onto 245 Post-it notes. The statements were clustered into codes. These codes were synthesized into themes of the experience with embedded rich quotes. I then reflected on these themes and through imaginative variation elicited textual patterns describing the how of the experience and structural patterns describing the what of the experience. From this, a textural structural composite emerged, an overarching theme or pattern describing a universal essence of the phenomenon of becoming a nurse health policy advocate. This study had 5 iterations. The first there was 12 interview transcripts from the 12 interviews. The mean length of each of the interviews was 25 minutes and 52 seconds. Significant statements were then gathered from transcript text and were written onto 245 Post-it notes. 42 codes were then created, and significant statements were categorized into codes onto 4 wall charts. 12 themes. Codes with like meanings combined significant statements under one theme until 12 themes emerged. These themes were entered into Navivo 10 as nodes, and significant statements were entered under the nodes. Interview texts were then summarized into these 12 themes, and quotes were embedded in the summaries. 12 patterns or phrases then emerged from these theme summaries. 7 were textual what phrases, and 5 were structural how phrases. Then a textual structural composite formed, and then an essence or overarching theme was discovered. Saturation was reached when the codes were discovered. The approximately 245 significant statements were grouped into 42 codes, as seen on this slide. This was done by determining the defining characteristic or code of each significant statement, writing this code on a wall chart, and then posting the significant statement under the code. This was done to each significant statement until no new defining codes were found and statements were placed under pre-existing codes. This slide illustrates these 3 things. Number 1, the specificity of the multiple codes. 2, the amount of like codes with similar themes. And 3, the weight of each code characterized by the amount of significant statements under them. For example, identity had 21, political action had 17, and the importance of voices, 16. Social justice is also weighted, especially when all the like social justice codes are collected under that theme. Data analysis. The 42 codes were further coalesced into 12 themes. Each of these themes were coded into a node in NVivo 10 software. The significant statements were entered under the appropriate node within the software. Memoing continued as the significant statements were read again through the lens of the nodes or the themes. The interview text was then summarized into 12 themes, and quotes embodying the richest description were embedded into each summary to further visualize the meaningful units and emerging themes. The researcher was immersed in the data through reading, memoing, writing, and rewriting in this process. The 12 themes of the interview text are barriers, characteristics of health policy, demystifying health policy and advocacy, identity, mentors, motivation to act, nursing educating on health policy, organizing and leading through nursing groups, political action shaping health policy, working with legislators, social justice, and the importance of voices. Data analysis continued. Universal patterns were intuited first in the theme of identity. Personal meaning was seen as a driver for advocacy action. For example, Nurse 1 stated, "My personal commitment, looking and having access to health care for all people to be a right rather than a privilege." Nurse 2, quote, "The whole issue of social justice, that was core of me." Nurse 3, "For me, I always start where my heart is aligned, and I would say that to nurses, go where your passion is." Nurse 4, "This is part of who I am. That issue of social justice, part of how I live." Nurse 10, "When there's unfairness, that really bothers my core." Data analysis continued. Universal patterns were again seen in the theme of motivation to act. As I immersed myself in participant narratives of their lived experiences, unique behavior patterns manifested, such as participants repeatedly taking on positions of leadership and participants feeling compelled to step out on the public stage to engage in advocacy actions in response to a perceived need. The participants' unique innate processes responded to external circumstance through expressions of leadership and health policy advocacy. Data analysis continued. The goal of the Civic-Kolaski-Keene method described earlier is to describe a universal experience of the group through a structural how and a textual what scriptures. The five structural patterns were intuited from the 12 themes describing the how of the phenomenon of becoming a nurse health policy advocate. And that would be personal values, sense of responsibility, unique meaning and purpose, innate processes within the participants, and strong connections to their mentors. The 7 textual patterns or what of the phenomenon of nurse health policy advocate are nursing professional associations as the primary advocacy vehicle, a social covenant to speak up, unique behavior patterns, strategy to overcome, learning the process and adjusting actions and attitudes to fit, working with legislators and those with positions of power, and health policy and advocacy is understandable and approachable. Essence of the phenomenon, living from the inside out. Analysis of the interview text iteration after iteration raises knowledge from a level of facts to a sphere of ideas. The final iteration of the interview text intuited an overarching theme or universal essence from the relationship of the patterns and the textual structural composite as describing a primacy of a sense of purpose and meaning as precursor action in the lived experience of the nurse health policy advocate. It is this purpose and meaning that is catalyst for action. Since these inward innate processes are primary before the outward actions can occur, the universal essence of the phenomenon of becoming a nurse health policy advocate is described as living from the inside out. Trustworthiness. Qualitative studies establish reliability and validity through trustworthiness. Trustworthiness is composed of 4 criteria: credibility, dependability, confirmability, and transferability. Credibility was established through persistent observation of reading, rereading, reflecting, and memoing. Member checking further established credibility by summarizing each interview in important quotes and sending it to the participant to confirm the accuracy of the data and researcher perceptions. And credibility was also established through peer review. I relied on my capstone chair's expertise in qualitative coding to establish dependability through intercoder agreement. Confirmability was established through keeping an audit trail of iterations and practicing reflexivity or bracketing to minimize personal bias. Transferability was enabled through embedded rich thick quotes that allowed for the reader to validate study conclusions. Interpretation of findings. The research questioned what are the lived experiences of nurses who engaged in effective health policy advocacy role presented two paths of inquiry. The first was to describe the lived experience of the nurse health policy advocates through the 12 themes with embedded rich thick quotes, providing further illustration and transferability. The what of the phenomenon of becoming a nurse health policy advocate was even more succinctly described in the textual patterns. Nursing Professional Associations as primary advocacy vehicle, social covenant to speak up, unique behavior patterns, strategy to overcome, learning processes and adjusting actions and attitudes, and working with legislators and those in power, and health policy as approachable. Since this study is hermeneutic and therefore interpretive, the second and primary goal was to look for themes in the advocacy journey that would explain the engagement and effectiveness of these nurse health policy advocates. Themes manifesting the power of personal meaning were first intuited when analyzing the theme of identity. Further reflection on the interview text found this theme to be underpinning the whole advocacy journey of the participant. This line of inquiry continued when analyzing the theme motivation to act. Unique behavior patterns were seen in the lived experiences. These were examples when participants repeatedly took on positions of leadership or felt compelled to step out on the public stage to engage in advocacy actions in response to a perceived need. These innate processes creating effective engagement in health policy advocacy are succinctly intuited as the structural patterns of personal values, sense of responsibility, unique meaning and purpose, innate processes within the participants, and strong connections with mentors. These grouped together as personal meaning and purpose are the drivers of advocacy action. Theoretical framework, human becoming. Living from the inside out is defined in this study within Dr. Parse's theory of human becoming, centered around the major themes of her theory of meaning, rhythmacy, and transcendent. Parse describes meaning as foundational. This is reflected in the primacy. This is reflected in the primacy of meaning and purpose as seen in the study's findings. Rhythmacy is the behavior patterns created through human universe dialectic or interaction. And transcendence is manifested as the participants make the not yet a reality by acting in the present on perceived potentials for the future. Parse characterizes human becoming as a kaleidoscope where human becoming is the living process of the lived experience. Human becoming is guided by personal meaning and purpose in life. This is a living process as meaning and purpose guide and interact with persons and situations to co-create lived experience. The Lifeworld of Lived experience. Lifeworld themes are specific to hermeneutic analysis. Continuing with the imagery of the kaleidoscope from Parse, these themes describe our being in the world through four facets: relationality, temporality, spatiality, and corporeality. Relationality is described by Van Manen as a conversational relation with others that allows us to transcend ourselves. This relating to others was seen in two areas: participants building strategic relationships in order to reach advocacy goals, and participants defining themselves and their actions in relation to a mentor. Temporality is very much like Parse's transcendence. It presents time as nonlinear in that both the past and the future affect present action. Participants manifested temporality in their understanding of the process involved in moving legislation forward. They characterize it as very much a long game, and small accomplishments of collaboration or less lofty legislative changes in the present are seen through the lens of a future health policy change that may take years to push through. The lived world of lived experience continued. Spatiality is defined through what one is advocating for, where one is advocating, and who one is representing. Spatiality has to do with how one defines the appropriateness of the space in which one conducts advocacy actions. Participants illustrate spatiality through situational awareness of the impact of advocacy actions. Spatiality and advocacy evolves based on political geography, New York versus Virginia, whether one is advocating from a personal ideology or whether one is representing an organization or a group of persons such as a profession. Several participants stated that policy and politics are intertwined. Because of this, advocating spatiality is very intricate and a learned process. One must be able to publicly express when one is representing an employer, an organization, or personal views. Corporate reality is the influence of the body on advocacy actions. It was very prominent in the narratives of the lived experience in this study as relates to the disempowerment of women, racism, and vulnerable populations. Study findings in the literature. Primacy of meaning and purpose. The primacy of meaning and purpose as precursor to advocacy actions or living from the inside out as a mental model leading to advocacy actions was not seen in the literature. Warner's 2003 phenomenological themes of political competence that was described in the literature review were seen, but they were not the focus of this study's research questions. The study also agrees with the dissertation of Berry in 1989 on the political socialization of nurses, in that A, nurses are older with generally more education, B, they are not socialized politically through formal education, and C, they understand the importance of organized nursing to political roles, and D, nurses identify the importance of mentors. This study also supports the American Association of Colleges of Nurses 2006, DNP Essential 5, Healthcare Policy and Advocacy in Healthcare, by adding to the body of nursing literature addressing engagement and health policy. Recommendations. Through several iterations, the findings of this analysis describes the phenomenon of becoming a nurse health policy advocate as living from the inside out. This finding opens a new line of dialogue in the decades-long inquiry of how to grow the body of nurse health policy advocates. The primary recommendation of this study is for nursing leaders to begin a dialogue that considers the primacy of personal meaning and purpose in advocacy action. Further research efforts and strategic planning processes should engage dialogue and how to grow the body of nurse health policy advocates using this new mental model, living from the inside out. Recommendations for further research. Do nurses have cultural support from within the profession to step out onto the public stage to shape health policy? The public trusts us, but does the profession identify with this role? There is new advocacy space opening up as a recommendation from the 2011 IOM report, The Future of Nursing, is naming nursing as leaders in shaping health policy. And as these recommendations are being implemented. The report is quoted stating nurses must see policy as something they can shape rather than something that happens to them. Nurses should have a voice in health policy decision-making and be engaged in implementation efforts related to health care reform. Nurses should also serve actively on advisory committees, commissions, boards, where policy decisions are being made to advance health systems and improve health patient care. That's from the IOM report of The Future of Nursing. The homogeneity of age or older nurse health policy advocates also needs to be studied further. Berry in 1989 found that the political socialized nurses were older, and this needle has not moved despite the 26 years between Berry's findings and the current demographics of this study's participants. The fact that the nurse health policy advocates are older may not strike many as unusual. They have more experience, larger networks, more education, and potentially more time for health policy advocacy. However, history has provided many examples of younger or more diverse generations leading advocacy efforts on non-nursing issues, so this needs investigation. Countercultural influences of the 60s and 70s were also prominent in these lived experiences and provided some amazing stories and histories. The prominence of these influences are very interesting and should be studied further. The gravitas of the influence of these 12 participants have had on the profession of nursing, the formation of nursing's role in health policy, as well as shaping health policy in the United States is beyond the scope of this capstone. These lived experiences need further exploration in a body of literature that would allow for more expansive detail of participant narratives. Participants would be engaged as necessary for permissions in collaborations involving further exploration and research of this interview data. Finally, the position of the lived experience in the narrative of the nursing profession needs to be explored and honored for the power it holds to guide and create paths towards strengthening the leadership of nursing and health policy advocacy. Thank you for listening to my presentation.